in the Endoluminal Technology Symposium and Asian Urological Societies of
Recording in
Technology.
progress.
First of all, welcome to the first instrument. So 2022 ETS annual meeting. I'd like to thank you all to join us first instrument. So we have two sessions. So one session is a PCNL, and also two sessions is the ECIRS procedures. So today we focused on the percutaneous approach, and with combined with lateral internal surgery, I think, because the treatment of large kidney stones has dramatically changed from the conventional to minimally invasive surgery around the world. However, of course, conventional percutaneous approach is mandatory with indispensable treatment methods for all androgynes around 4 Asian countries. Therefore, so we need to share a lot of knowledge of now novel technique and technology and ideas for large kidney stone treatment. We definitely think today's our lectures and active discussions are very, very quite meaningful for all audience from Asian countries, I think. Once again, thank you for participating, joining to this first instrument of ETS AUSET annual meeting. Okay, so before we start, I'd like to introduce him. So Professor Sung-Yong chose. He is a very famous andrologist and also the clinical professors from Seoul National University, and also president of AUSET as well. Professor Sung-Yong, can you hear me? So please talk your comments about the AUSET.
Yes, I can hear you, and I'll share my screen to introduce.
Yes.
The AUSET. Can you see my slide?
Yeah, right. I can see.
Okay. Good afternoon, ladies and gentlemen. So sorry, my camera doesn't work, and well, anyway, nice to meet you all, and good to see all of my friends here again. It is excellent thing for me to that I can have the opportunity to introduce the ETS Symposium and the AUSET Association. You can see the new name of AUSET, Asian Urological Society of Endoluminal and Technology, on the endoluminal.org homepage. As you know, some Asian experts in endourology have organized the ETS Symposium since 2018. We have tried to introduce advanced surgical approaches in endoluminal endourology, investigate and evaluate notable medical technologies, and build the future by transforming historical approaches and integrating with innovative technologies. Now, so we start a new specialized association named AUSET. It aims to share knowledge and experience with more Asian urologists, establish a stronger yet specialized network, and make the ETS Symposium one of the world leading conferences, and provide the most up-to-date information. The team Korea with good surgical skills and high-quality academic activities will fully support all the ETS symposiums and the AUSET activities. Until now, I have performed about 160 times of presentations across the world and met many urologists in the field of endourology. While I traveled across the many countries in my early experience, I confess, I try to search for what the best is. But it didn't take long to realize that there was no best thing in everything regarding surgical techniques or academic research. Instead, high-quality surgery and academy and challenges to overcome the hurdles were essential with limited resources, especially in Asia. So what we need to know about, I thought at that time, was how we can develop together. And we need to see similarities and differences first. And we overcome some hurdles, and then we see other similarities and differences again. So only what I had to do at that time was that I needed to find the good, active, diligent friends to do this together. And we are now together in the ETS symposiums, and I feel so extremely happy with this. We don't need to gather much money as other associations or symposiums do. So we are organizing a small specialized sessions about endoluminal endourology with excellent Asian friends, and regional debates and meetings in other provinces were arranged in advance. And almost all lectures were based on video clips, and we focused on various surgical tips and tricks with live or semi-live surgery on many days. And ETS started with 3 simple but fundamental aspects for medical professionals: be practical, be academic, and lastly, the link technology and expand the network by linking global experts in one place. Unlike other conferences which are limited in how many presenters sessions it can serve, ETS tried to run on the basis of the participants' input and feedback. So we incorporated a massive online open courses platform. It allows all the participants to have their fair opportunities to say something about the urology. And we believe that there are no such things as silly or stupid questions about endourology. After 2 successful online meetings, we faced the era of COVID-19, and we planned a unique program platform of 5 monthly installments with active, young, and starry secretary urologists in Asia. And many participants from many countries, not only in Asia, but also in other countries, joined the ETS symposium in 2020. And we had more than 200 registrations from more than 30 countries. Now we can see the fourth event of ETS 2022, and I'm so happy to see you joining here, and we can discuss everything for endourology together today. And our Japanese and Malaysian friends will open the first event today. When you saw the abstracts about RIRS and PCNL in UAA conference in 2020, we could see the many cases of flexible URS and mini PCNL. And new technology seem to be widely accepted and investigated in many Asian countries. So, and many friends are still visiting other places and discussing many things in endourology, and we can collaborate online as well. Yeah, my final take-home message is, by teaching, we can learn. And now we have AUSET and ETS. Please enjoy today's event, and thank you, especially Dr. Inoue, for today's event. Thank you so much.
Thank you, Professor Charles. So thank you for your great talking about AUSET ETS. Okay, so we don't have much time to start. Okay, so let's get started. First sessions. So before we start our first sessions, so if you have some concern, query, questions for each presentations, you can use the Q&A box. So in a Zoom platform below. During even talking, so please fill out your query questions. Okay, let's get started. So we have first sessions. We have 2 presentations. First presentations is a patient procedures from Malaysia side. So in Malaysia countries, so they performed a lot of patient procedures, I think. So first talk is a tip and tricks of PCNL procedures by Professors Islah Rashid from Mauritius. He is now Associate Professor and Consultant Urologist in the International Islamic Universities Mauritius. Professor Islah, can you hear me? So time is yours. So please talk your presentations. Please start to the pre-recording video. Okay, great.
Thank you very much for inviting me for this ETS. I was given the task to talk about tips and tricks of successful PCNL. So this is the first Endoluminal and Technology Symposium in Seoul in 2018. I met all these very recognized endourologists. Lingerman's law for management of nephrolithiasis. If the stone problem is simple, any intervention will be successful. If the stone problem is complex, perform percutaneous nephrolithotomy. So what is successful PCNL? Successful PCNL should be safe and effective at a good high stone clearance rates. So we will be talking about the pre-puncture, during puncture, and post-puncture during the PCNL. So this is the thing that should be considered pre-puncture. The pre-op imaging, the positioning, types of PCNL, and the retrograde pyelogram. Intravenous urography used to be the standard imaging before we proceed with PCNL. However, it is replaced by the plain CT. Contrasted CT gives more ideas about the system, but CT with 3D construction is the best imaging if you want to plan for PCNL. Prone versus supines. For me, there is no best positions. There are certain PCNL which is better done in prone position. There are certain PCNL which is better done in supine positions. So this is the commonly used supine position, the Valdivia positions. UST makes some modifications, and this is the most popular Galdakao modified Valdivia position for supines. This is actually my case, which I did in prone position. The left picture shows during the retrograde pyelogram and the right during the prone position prior to PCNL. This is a morbidly obese patient. So even in a morbidly obese patient, prone PCNL can be done safely and successfully in a morbid obese patient. So this is the case. This is actually at the end of the operation where I almost cleared everything. So there are many types of PCNLs. The nomenclature from standard, mini PCNL, ultra mini PCNL, mini micro PCNL, micro PCNL, all have their advantages and disadvantages. This is the evolution of endourological treatment from PCNL, the standard PCNL, to the mini PCNL, from prone position to the supine position. Even we combine it with the flex URS to have a bidirectional bilateral approach, ECIRS, and sometimes we can use the intraoperative flexible nephroscope to get a good stone clearance rates. However, in this kind of patients, complex renal stones such as complete staghorn, multiple staghorn in different calyces, abnormal anatomies, I prefer to do multipuncture PCNL. So this is one of the cases that I did multipuncture PCNL. I did a lower pole puncture with the standard 20 for French and upper pole puncture with 20 French ample shape. So this is the lower pole puncture, which is 24 French. This is 20 French upper pole punctures. So, but I actually convert the 20 French upper pole puncture to 24 French ample shift to get a better stone clearance rates. And this is at the end of the operation where I put the Malikoid catheters. So this is the end of the operation. I have a good 100% stone clearance rate in these patients. So whatever you use, either mini PCNL, standard PCNL, supine PCNL, prone PCNL, lateral PCNL, Valdivia, QST, you have to use your weapon wisely. Sometimes you are good in swords, like these Olympic champions, Irina Deriglazova. Or sometimes you are good in archery, and sometimes you are good in gun. So you use whatever you are good in. In retrograde pilogram, actually, there are two kind of pilogram that we can use, the air pilogram and the contrast pilogram. The principle is air goes up, the contrast goes down. So in prone positions, air pilogram will delineate the posterior calyx, which is the most common calyx that we want to puncture. In supine position, the contrast will go at the posterior calyx. So in supine position, contrast will help to delineate the posterior calyx. In terms of the catheter placement, the best is to put at the calyx to be punctured. Why? Because it will distend only the mainly intended calyx. And if there is any contrast extravasation, we can actually use this urethric catheter as a guide. We can puncture to the tip of urethric catheter. So this is an example. This is actually not, I'm puncturing at, this is one of the multi-puncture PCNL, actually puncture actually towards the wire, because I know that the wire is at the upper calyx, and you can see there is some contrast extravasation. So because of that, I didn't inject more contrast, because it will actually cause more problem for me. So I'm targeting this wire to get into the systems. During puncture, there are a few things that we can consider: the imaging choice, the calyxal choice, dilatation choice, number of punctures, and size of tract. So there are three most common way of imaging or to guide your punctures: ultrasound, fluoroscopy, endoscopy. Fluoroscopy is the most commonly done. Either it is bullseye, ligament, triangulation, combinations. Ultrasound has the advantage of less radiation, real-time imaging. However, it has a steep learning curve. You have to learn ultrasound well. Endoscopic guided can be used as part of ECIRS. The ideal track for punctures is the shortest, the straight, and direct path along the axis of calyx through papilla. So this is the thing that we should consider. So how about the puncture site? Posterior calyx versus anterior calyx. Definitely posterior calyx is the most commonly and the best choice for punctures. However, anterior calyx sometimes need to be punctured if the stone cannot be accessed by the posterior calyx punctures. Upper calyx, middle calyx, and lower calyx. So how do you choose it? So lower calyx is the easiest calyx to be punctured. Upper calyx sometimes is difficult because of the pleura. However, upper calyx is one of the best puncture to get a high stone clearance rate. So this is actually this is the multi-puncture PCNL that I did just now. I actually puncture at the lower calyx, but later when I cannot clear all the stone, I use these punctures to bring down the kidney and puncture the upper calyx. So actually I'm away from the pleura itself. So there is also, we have to balance or weigh a difficult puncture with easy stone clearance rate, which is the upper calyx punctures, easy puncture and difficult stone clearance rate, which is the lower calyx punctures. So there is no rules for punctures. Commonly, the desired calyx is the posterior calyx. We should try as much as possible to puncture at the papilla to avoid bleedings, and always better to enter via opposite calyx if the stone is at poles, and pelvic stones are best managed by upper or middle calyx punctures. Lower pole punctures, like what I mentioned just now, is easy for newcomers. However, it is the most unfriendly in PCNL, usually owing to its anterior tilt. You have many techniques: the bullseye, the ligaments, the triangulations. Actually, if you ask me, we have to master all the techniques. You can use one technique as your main techniques, but sometimes you need other techniques to have a better stone clearance rate. Sometimes you even combine the techniques. How do you know a puncture is successful? Usually you will have a gift, urine will come out. However, if there is bleeding, sometimes urine doesn't come out. Methylene blue can help in identifying the tracks. Sometimes you can aspirate to make sure you are in the system, and sometimes you can rub the stone by your needles. This is the three most common dilators that we use: the alkane metallic dilators, the unplus Teflon dilators, and the balloon dilators. Alkane metallic dilators is the most traumatic. However, it is useful in cases where there is a very fibrotic tissues. So that even though it is the most traumatic, it is useful sometimes, beneficial sometimes in certain cases. Unplus Teflon dilators, I think one of the most common dilator that we use. The disadvantage of unplus is that it is a serial dilatation that you have to go in and go out. If your wire is not well secured, you have the problem, sometimes the wire will come out. To solve this problem, sometimes we just jump the size, or sometimes we just use a single dilatation techniques. However, in a very fibrotic tissues, sometimes these unplus Teflon dilators cannot dilate the tracks. Balloon dilators definitely is the best because it is a single dilatations. However, it is expensive, single use, and of course, in a very fibrotic tissues, sometimes you cannot dilate the tracks. How about the size of the tracks? Of course, a larger size is more difficult, sometimes a lot of bleedings, but it gives the advantage of lower intrarenal pressures. And of course, you will have a better view of the systems, and you can use a lot of varieties of endoscopic armamentarium such as forceps, ultrasonic probes. So you have more weapons to use. For the smaller size, it has the advantage of less bleedings, less complications. However, it has the disadvantage of increased intrarenal pressure. Sometimes the view is not very good, and you have only limited armamentarium to be used. This is to bear in mind that if you have problem in dilatations, to underdilate is better than to overdilate. Why? Sometimes you have to only dilate up till the calyx. Don't go further into the pelvis. If you use mini PCNL, sometimes you don't confront with any problems. However, if you use the standard, especially you use up till 30 French, if you try to put or dilate to the renal pelvis, if the infundibulum is narrow, it will cause shear of the mucosa and bleedings. To underdilate is better. Even though you are in the renal parenchyma, you can actually use the guide wire to guide you, or you can actually inject a methylene blue to get into the systems. Nephroscope choice, lithotripsy choice, intraoperative flexible nephroscopy, simultaneous and non-simultaneous ECIRS is the one that you consider post-purchase. So this is the left top is the old litho class, which I have not using it for more than 10 years. You can use this litho class, is good for hard stones, but now we have this EMS which combine the litho class and also the ultrasonics. So we get both the advantage of ultrasonic and litho class for hard stones. Lasers is very good, the Moses, the thulium lasers. However, which one is the good one, the best one? Actually, there is no best. If you look here, laser is very good. Hard stone even can break. But if you have this kind of matrix, you can see that the laser doesn't function well. It doesn't break, because it is a soft tissue. The laser will not break it, and it doesn't work. If you use this is the ultrasonic for this soft stone and also the matrix. You can easily suck out all this matrix. So there is no best things in PCNL. There's always you have to tally according to your needs. So for my opinion, laser is good in micro, ultra mini PCNL and mini perks because laser is small. And of course in supine position because you have the advantage of the gravities. So the stone will come out with lasers dusting fragments. However, in prone position or in a very complex large stones, ultrasonic is good because in prone position, you are actually doing against the gravity. So you need something to suck out the stones out. Or laser is not good in prone position because it will cause a lot of small fragments which will go everywhere in the systems. Litho class, even though it is old times equipment, it is good in a hard stone. You have this multi-PCNL, ECIRS, intraoperative flexible nephroscope, second loop PCNL to get a better stone clearance rates. So you have this. This is one of my case, actually the obese case just now. So actually this one I'm using the flexible nephroscope. There are one calyx that I cannot access using the normal rigid nephroscope. So I use the flexible nephroscope and use my basket to take out the stones. So this is the stone that I tried to take out. You can see here, this is the stones. However, once I catch the stones, actually the stone stucks. The stone stucks here. So I have to take out, bring out my flexible scopes and use my rigid scope. And with that rigid scope, I catch the stone using the forceps. So this is the good thing about standard PCNL, that I can use more equipment to help me. So then, once the stone is out, then I break the stones. So I break the stones. Yes. So, in my opinions, actually, there is no best things in PCNL. Supine is good, prone is good, mini PCNL is good, standard PCNL is good. What is the best thing that you have to do is you have to master one techniques as your main weapons, like this samurai. They are good in swords, but they can use other weapons such as the arrows, such as this commando. They are good in machine guns, but they can use the revolver to help them. So you have actually, if you want to be a good endourologist, you have to master everything, or at least majority of things, and use it accordingly. So hopefully the COVID will calm down. We can enjoy these beautiful sceneries. Thank you very much.
Okay, so thanks for a great, excellent lectures. So Professor Islah. So maybe we have some queries, but so maybe we have discussion time afterward for 20 minutes. So after second presenting from Dr. Kate, so we will request it. So afterward. Okay, let's move on to the next. So second presentation in the first sessions. So next speaker is Professor Git Kah Ann. So he is now consultant urologist at the Pantai Hospital Penang, and also the director of andrology of the Malaysian Urological Associations. His topics is very, very impressive for me and for audience, I think. So this topic is the troubleshooting and sharing the case in PCNL of Malaysia. Professor Kid, the time is yours. Please talk your presentations.
A very good afternoon, ladies and gentlemen, and to my friends in Japan, konnichiwa. Today I'm given the task to talk about troubleshooting in PCNL. First, I would like to thank the Asian Urological Society of Endoluminal and Technology for inviting me to give this talk. I'm speaking to you from Penang. We don't have to fly to Japan to meet each other, and we can meet online now through this webinar. And Penang is the island which is located at the north of Peninsular Malaysia, and my hospital is located at the southern tip of the Penang Island. I wish that one day I can invite you to all of you to come to Penang to enjoy the beautiful beach at sunset and enjoy the sumptuous street food which Penang is famous for. Ladies and gentlemen, the topic today I'm going to share with you is troubleshooting in PCNL. Thinking about how to present this topic, I thought I'll break it down into how not to get into trouble when doing PCNL, and subsequently going through all the various steps of PCNL and how to troubleshoot each step from putting in catheter, puncture, dilatation, stone clearance, and putting a stents and a nephrostomy tube. Not all difficult PCNLs are difficult, and not all easy PCNLs are easy. If you have done enough PCNLs, you will get in trouble. and it's important to get out of trouble and learn from it. The best way to learn is actually to observe those mistakes that's done by other people. And if you've seen mistakes, or if you've done some mistakes, discuss. And this is like, for example, this forum is actually quite a good forum to discuss about mistakes and how to get out of it. And of course, the most important is to experience those mistakes that you have done and learn how to get out of those trouble. And I find teaching is a very important way to learn from the mistakes of others, and you come in to help bail them out, and you learn from it yourself. Now, patient selections and positioning. Select your patients well and plan your PCNL. The best way to get out of trouble is basically not to get in trouble in the first place. So you should ask yourself, is PCNL the best way to get the stone out? And plan your surgery, plan your PCNL. Do I anticipate any problem with PCNL for this patient? Is there any risk of bleeding, any risk of sepsis, the stone anatomy, any risk of lung injury and anesthetic problems? And ask yourself, how should I approach the stone, be it upper pole or lower pole puncture, supine, or prone positioning? For example, if you have a patient with this kind of stack horn calculus, you probably do not want to do a mini or micro PCNL because it's going to take ages and you can see the stone is pretty hard. Now, patient positioning is important, and I feel it's important to prepare to troubleshoot problems in PCNL and give you the freedom to get out of trouble. There are several positions, being prone, supine, or the Galdakao modified supine Valdivia position. And that's the prone position, the supine Valdivia position, and I prefer the prone flex position, which is more ergonomic. And that's when you're preparing for ECIRS, you put the patient on the Galdakao modified supine Valdivia position. So that gives you an option of doing ECIRS. Supine being an anesthetic friendly position. If you put the patient prone, these are the tips you can troubleshoot when you get into trouble. And this is how I like to position my patient. As you can see, the pressure points are padded. The patient is on the flex table in the ergonomic flex position, and you can see there's enough space for the image intensifier below the patient, and that gives me a lot of freedom to move the C-arm. The patient is tightly strapped up. That gives me the option of tilting the patient away or tilting the patient towards me. And I put a roll towel underneath the patient, underneath the kidney. As you can see, there are various shapes and sizes of the roll towels that I can manipulate intraoperatively to move the position of the kidney when I'm trying to puncture. So that's the skin marking of the patient. As you can see, it's a very wide space. I got the option of coming in from upper pole, lower pole, or as well as a mid pole. Now, putting in a retrograde catheter has got its issues as well. In fluoroscopy guided puncture, RPG and catheter is required. In ultrasound guided puncture, I'll always try to insert a catheter anyway. Now, one of the common problem is, what if the catheter can't go through the stones to give you the pyelogram when you want to do the fluoroscopy guided puncture? Well, you can do an RPG and assess and see whether there's a way in. It's a trickle or contrast, there's a chance you can get a wire through. If you can't, you can always convert to ultrasound guided puncture. Use a slippery wire. Will be a very, very useful tip for you to try to get a wire through a very, very tight impacted PUJ stone. If you fail, you have the option of passing out a ureteroscope. You can use laser lithotripsy to break the stone as you're trying to go through, and continue on with your PCNL. Now, what about the puncture? How to troubleshoot puncture? Very important to understand anatomy. Remember that on the right side there's a liver, on the left there's a spleen, and up right above is the lung. So knowing your anatomy is actually very important to troubleshoot PCNL. For example, if you have a kidney shape which is like this, with a narrow infundibulum, doing an upper pole puncture is not a very smart thing to do. Look for the posterior calyx and get a lower pole puncture to clear that stone. If you got a kidney that looks like this, and this is where the stone is located, the staghorn is located, you can do the puncture from the upper or the lower pole, and that shouldn't give you much trouble. But if you got a stone which is going down into the ureter at the PUJ, probably upper pole puncture will be better because it's more ergonomically sound. If you're doing low pole puncture, there's an acute IP angle, and you're going to torque a lot of the kidney, and it's going to cause a lot of bleeding. Now, what if you have done a puncture and your puncture is too deep? Don't worry. Withdraw the needle while aspirating. Chances are you're going to be able to still get into the system. If you have gotten into trouble with a lot of extravasation of contrast, don't insert a high pressure contrast in the first place. If you have done that and there's a lot of extravasation, try to recite your puncture. If you can't and still have to go through that calyx, you wait for a while, the contrast will diffuse away, and the good way is actually to aspirate out the contrast within the renal calyces, and lowering the pressure, the contrast might diffuse away and you can restart your puncture again. If you need, you can push in a bit of air and give you an air pyelogram and puncture it using an air pyelogram as a guide. Knowing the kidney anatomy is also very important, knowing where the arteries are, and basically if you're going to puncture through the segmental artery or the interlobar artery, you're going to get into trouble with a lot of bleeding. When we do ananthropic nephrolithotomy, we know where the avascular plane of Brodel is. Similarly with PCNL, getting into this plane, into the calyx, will reduce a lot of problem with bleeding. Now, studying the CT scan is also very important. You want to get out of trouble, look at this CT scan. It's got a retrorenal colon. So if you're going to puncture the kidney, be careful of those colon. If you do get a coronary injury, you need a high index of suspicion, because basically often it's not identified until you've completed the PCNL. When you withdraw the nephrostomy tube, then we realize that there is extravasation of contrast. Don't worry, put in a stent, put in a nephrostomy tube, make a controlled fistula, then withdraw the nephrostomy tube to the colon after a couple of weeks, and eventually you get a controlled fistula, and very often if there's no distal obstruction, the fistula will close. Now, troubleshooting dilatation. Many methods to dilate, and basically my advice to you is do what you're familiar with. I give you a scenario. The Y is just in, very often you get that. The dilatation is just outside the system, or the dilator and amplassis is just pushed too deep. You can't really get into the system. It's very important to have a steady hand. Don't stray away guided by the fluoroscopy. The kidney is not very far away. Use methylene blue to identify the system. Use forceps to dissect the kidney as you're trying to get into the calyx. Look for the stone or look for the retrograde catheter, and you know you're going to be in. How about a scenario when the kidney is very mobile, or it's very scarred, or it's very hard, and it's very difficult for you to get the dilators in? Do a sequential stage dilatation instead of single stage. Anterior support on a prone PCNL, like I've shown you, where I put a rolled towel under the patient. Use balloon dilators in this scenario where the kidney is very scarred or very hard. And sometimes you have to recite your puncture to go to another site where there's less scarring. Now you can dilate just outside the kidney, and if you can't get in, rather than losing your way, you can dissect in through using a forceps. Now, how to troubleshoot stone clearance? To troubleshoot stone clearance, study the renal anatomy, look at the CT scan, study it very well, identify the locations of all the stones, look at the safest approach to enter, look at where the approach has got the most options, the best outcome, and prepare for exit strategies. Now, stone clearance is also need to be balanced with the number of punctures that you're going to do and how much you're going to torque the kidney. Sometimes stone clearance have to be compromised for patient safety. Now, this is the picture I showed you earlier. So that tells you the options to approach that give you the best outcome for stone clearance. Now, if you got a stone which is on the posterior lower pole calyx in a prone upper pole puncture PCNL, you can actually tap the stone and drop it. So those are the stones that you can see but you cannot touch. Tapping the back may drop the stone into somewhere that you can reach. I find that PCNL basket is very useful. You can manipulate the basket into hard to reach places. And sometimes if you got a calyx, rather than doing multiple punctures and multiple dilatation, just do a single needle puncture to the calyx. Sometimes you're able to push the stone into the renal pelvis and collect it. The biggest problem doing stone clearance is actually bleeding. So if you've got an area where it's bleeding, stop for a while to allow it to clot and come back later. Very often the bleeding will stop, and when you come back later, the bleeding will not be so torrential. Now, losing the track when you're a bit slipshod sometimes can happen. Make sure the wire is always in the ureter. Then even if you lose your unplugged sheath, you can get back inside again. Don't panic, and sometimes methylene blue does come to the rescue to find your way back into the system. Very often in obese patient, your unplugged sheath may not be long enough, and sometimes it can slip below the skin. If you have a very obese patient, suture the outer end of the unplugged sheath just in case the unplugged sheath fall under the skin. Now, ladies and gentlemen, what about troubleshooting stents and nephrostomy tubes? Stents are very good, full godsend, get out of trouble cut, but stent insertion in PCNL has its problems as well. Stents can be pushed too deep into the ureter, so very important, don't cut the suture when you're pushing the stent, then cut it later when the stent is in good position. If you have inadvertently pushed the stent too deep, push in an open basket with a basket wire trapped in the guide wire. Under fluoroscopy guidance, you can actually trap the stent and pull it back up again. Now, nephrostomy tube is not always necessary. You can do a tubeless PCNL, but it's useful when you have encountered bleeding. It gives you a good tamponade, and it can actually clot up the stents to reduce the bleeding. It's okay to place a nephrostomy tube even outside the kidney because it will drain the kidney as long as you have a stent and there's no distal obstruction in the ureter. In bleeding cases, there are several things you can do to troubleshoot. For example, you can cauterize the bleeder using a Bug B. You can use a tamponade balloon. Very often, I just clamp the nephrostomy tube. Eventually, the bleeding will stop. There are many gelatin matrix material like flow seal and gel foam that you can use to reduce or stop bleeding. Now, troubleshooting post-op care. For example, did I cause a hydrothorax? You can use the II when the patient is still in the prone position at the apex of AC lateral lung. Significant hydrothorax can be seen as the water accumulates in the apex. Now, it's going to have a risk when you look at your nephrostomy tube, it's full of blood, it's bleeding. Clamp the nephrostomy tube and wait. Very often it will stop. And if the patient has difficulty breathing or the oxygen saturation is low, think about hydropneumothorax. If the patient has pain, whether they have got any pulmonary embolism, you might want to do a chest x-ray, give the patient adequate analgesia, and always have a high index of suspicion. So in conclusion, ladies and gentlemen, as I showed you these beautiful 4 tenets of learning from troubleshooting PCNL, you observe, you discuss, you experience, and please teach. And by teaching, you actually learn yourself. So ladies and gentlemen, plan your PCNL very well. Learn from the mistakes. Don't just forget about it. Always plan for an exit strategy whenever you do a PCNL. And I leave you with this quotation of mine. Endourology is a field of urology that we always plan to change our plan. Thank you.
Thank you for your great presentation, the Professor Kit, and also the Professor Islah. So we have some questions from audience about our past sessions, PCNL question from the Malaysia side. So can you ask some questions? So is that okay? So Professor Islah and Professor Kit?
Yeah, I can answer the question.
Yes.
Okay. So from audience, we have one question night. So Dr. Sung-Yong has already answered from this session, but so we have we wanted to correct from another countries. So one question is, so after PCNL procedures, what is your cutoff diameters? 2 millimeter or 4 millimeter or 6 meters? So about the reader kidney stones, residual remained kidney stones, remnant stones.
You mean is during the operation or after the operation has finished.
After operation.
Actually, if during the operation, I prefer not to leave anything. If it's just like doing the RIRS, something like that, just leave some dust. After the operation, usually I usually leave the nephrostomy tubes. I usually left a nephrostomy tube in my PCNL. So if there is any evidence of stones, which is in the kidneys, I will put the patient for a second look PCNL. This is only done under local anesthesia, just to pick up using the baskets.
Okay, I get it. So maybe these are stones, remnant stone sizes. So maybe 2 millimeter or 4 millimeters, over than 4 millimeters. So maybe which is a cutoff?
I usually use the 4 millimeter ones if there is a residual. 4 millimeter ones. 4 millimeter. 4 millimeters. 4 millimeter. Yes.
Okay, I got it. Thanks again.
But normally I don't like to leave any stones. If there is a stone, that is considered the residual.
Okay, thanks again. So how about so maybe Professor Kidd? How about his opinion regarding with this topic?
Yeah, I have problem because I can't get my video started. But anyway, okay, you got a video started. Well, it depends on the how I want the stone to be cleared. Obviously, when I plan my PCNL, I do it in a planned way that I know I left some stone behind. So intraoperatively, I have to decide, am I going to do a second puncture? Am I going to put a nephrostomy tube? Am I going to come back for a second look? Or am I going to just leave the stone behind? Am I going to do a sandwich therapy where I can do ESWL in the future? So there are various ways depending on the patient to decide. Patient safety is very, very important. So if I'm going to spend another maybe an hour in a patient who's bled quite a bit to put a small puncture to clear a 5 millimeter stone, in that kind of scenario, probably leave it alone, something like that. Yeah.
So how about less than 2 millimeters? These are stones.
again, I think it depends on the patient, where the location of the stone, renal function, and how much I want to clear the stone. It comes back to your clinical judgment.
Okay, I got it. Thanks so much.
Dr. Inoue, may I answer the Prof Cho questions just in the chat?
Yeah, I got it.
Yes. There is a question about the proportion of RIRS, mini PCNL, conventional PCNL.
Right.
Okay, prone supine. This is always a debate about this. Okay, like Dr. Kidd, I think we in Malaysia has been trained with prone PCNL for more than 10 years. The standard PCNL. I actually do all this type of RIRS, PCNL, supine PCNL, mini PCNL. All I do. But the main way I'm doing it, just like what I said just now, the samurai, my sword is prone PCNL, standard PCNL. In the case in which there is the patient is not surgically fit for PCNL, then I will do RIRS for smaller stone. Or if in the simple stones, such as the renal pelvic stone is quite simple stones, big renal pelvic stone, such 2.5, 2 centimeters, I will use the mini PCNL as my weapons. So actually I do everything, but my main PCNL is prone standard, which is I use the 24 French. I don't go up till 30 French anymore. And then I use the pediatric nephroscope for a simple renal pelvic stones. I just dilate up till 20 French and use the pediatric nephroscope, because the pediatric nephroscope I still can use the ultrasonic probes.
Okay, great. Okay, so this method is so maybe Malaysian standard, right?
Not standard. There is no rules. There is no rules. There is no rule. There is always a good taste. Yeah, you can do supine, you can do ECIRS. In Malaysia, you can choose whatever you want to do. But this is because we are so trained on prone PCNL.
Right.
And I don't have problem with prone. My anesthetist don't even complain about putting the patient in prone position. My anesthetist, nothing happens in prone positions, and even when we position the patient to prone, it takes only about 5 to 10 minutes, not much of times.
Okay, I got it. So we have another question from audience. Can you ask? Okay. So from the Professor Kidd. So question is, during standard PCNL using 24 French more than French thesis, I usually apply resect scope to coagulate the focus of bleeding after PCNL. I mean this from the tract side. It don't guarantee to stop bleeding. In many cases, it is very useful. So I wonder, so how speaks? So think about it. Maybe
Yeah,
I
that's
take
a
a coagulating method.
Yeah, that's a very good question. As we do TURP, we see bleeders and we put a resectoscope, we can stop the bleeding. You put in a catheter, you're very, very happy. Yeah, that on that principle, it works very well. But the only difference in the kidney and the prostate is if you got a torrential bleeding, it might be an infundibular segmental artery bleeding, which sometimes the bug B, or if using your resectoscope, you may not stop the bleeding. It will stop parenchymal bleeding, which you're going to put a catheter in, you're going to put a nephrostomy tube in, likely it's going to stop the bleeding anyway. So yes, I think I have done it. I have put in a resectoscope, but remember, a resectoscope is quite big, so you need to have a huge 30 French unplugged sheath. If you're going to use a small unplugged sheath, your resectoscope is not going to go in, but you can use a nephroscope and a bug B to stop the bleeding and coagulate the parenchymal bleeding. I've done a few cases where I need to coagulate to make myself satisfied, but at the end of the day, being a little bit lazy and a little bit more experienced now, I just leave a nephrostomy tube in. If I see blood, and I just clamp it. Just to sidetrack a little bit, through the years, what I've learned is don't cause bleeding in the first place. Do a good puncture. I almost always do an upper pole puncture. So you do upper pole puncture, the ergonomics is on your side, the kidney is facing you, and you try to get into a nice plane, do minimal torque to the kidney, and you won't have a lot of bleeding. So I think prevention is better than cure. But if you have to use resectoscope, by all means, go ahead and do it. Remember, you have to change your cell to glycine if you're using a monopolar. So there are a few other factors to put into consideration. Your bug B will not work in a normal cell line. You have to change to glycine. So a few factors you have to take into consideration.
Okay, I got it. So maybe so coagulation methods after procedure is not indispensable. So in the Malaysia countries, so does it make sense? Does it?
Yeah.
Right. Okay. So maybe in Japan, so some institutions, so maybe coagulation method using resectoscope used to stop the bleeding after procedures. Yeah, but not mandatory, so not common, so in use. Okay, so maybe one more question from Sung-Yong chose. So maybe what method do you choose if a patient has big stones in the left kidney and also there some small stone in the right kidney? So what choose? What kind of choose? So maybe you choose a method. Left kidney big stones, right kidney small stones. What method do you choose?
Okay. Maybe I'll just answer that question first. A very good question. I see that very common. In fact, one of the cases that I was supposed to share is actually a similar scenario. So what I would do is, okay, you're going to spend maybe like 2-3 hours or 2 hours doing a huge staghorn on one side. So you may plan to do a bilateral PCNL at the same sitting, but you're going to do a huge stone, be it on a supine, a prone PCNL. It's going to take a lot of time. You probably want to reserve that for another day if the treatment of choice is PCNL. Now, you've got an option of doing supine PCNL. Positioning, you have to reposition again the patient. Is not so easy, but you got the option again. The next one would be ECIRS. But trying to do a huge stone staghorn with the ECIRS, again, is very difficult. If you're doing ECIRS, can we go and attack the small stone with RRS at the same sitting? Then there are many factors to consider. So patient factor, time factor, cost factors, and all these take into consideration. The options are open depending on patients. Yeah, you can clear all stones together in one sitting, or you can leave it to 2 separate sessions. Again, it's basically patient-oriented, safety-oriented, and how much it's going to cost you.
Cost, okay. So how about this? How about this? So Professor Islah.
My opinions. Okay, actually, there are few options that you can do. One is definitely the one that Prof Inoue and Prof Sung-Yong like to use is the ECIRS. Okay. Okay. All right. The supines, PCNL and ECIRS. Okay. So you can another way if you still want to do in the prone positions. Another way is like what Mr. Git said. We do one stone at one time. We do one stone, the right side at one time, and another stone at another times. That's another thing.
One stage.
One stage.
Yeah.
Another thing, if you still want to do in prone position, there is no problem actually. We just finished the left stone by RIRS, because anyway you have to do a retrograde pyelogram in a lithotomy positions. So you can do the RIRS for the left stones, the small stones, and then turn the patients, put a catheter, turn the patient to the prone position, and do the prone PCNL. So actually, the option is there. So which one do you choose? Which one do you master with is the thing that you should consider.
Yeah. Thanks again. So maybe I think, so in my opinion, so maybe, so one procedures in left side kidneys, one procedures in the right side kidney. So maybe different. So maybe I think different populations, I think. Yeah. So just so final questions from audience. So maybe we don't have any case report to discuss. I'm sorry that so maybe the Professor Kid. So final questions. So from audience, what's the role of gram stains of the urine above the stone obstructions to find out miss the UTI prior to PCNL? So how about, do you think, so this, so maybe it's concerns. So Professor Kid.
Yeah, that's a very good question, because PCNL sepsis is one of the main cause of morbidity. Yeah. So you're worried whether you're going to end up with a urosepsis after your PCNL. As you know, you asked a very good question, because if you do a urine culture for the patient and you find no growth, it doesn't guarantee you'll not get a PCNL sepsis, because there are many studies that's been shown to show that the germs in the kidney may not be the same with the germs in the bladder. So if you have facilities and you're in a big center where it's very easy for you to do a gram staining of the urine, by all means go ahead. And that will probably tell you, yes, there's a gram-negative bacilli within the urine of the kidney. Now, studies have shown that a majority of stones, especially stones in Asia, they are infected stones. So chances are you're going to be positive. So what are you going to do? Are you going to stop the surgery, put in a nephrostomy tube, or put in a stent and come back another day? You end up doing that for more than 50% of your patients. So for those of us, and the majority of us who do not do a gram stain, just do a simple urine culture. And what I do, I go clinical, whether the patients have any signs of infection in the kidney. If there are none, I go ahead with my PCNL. And how many patients do I have that go into PCNL sepsis when I know that I know the procedure will be relatively safe? Very, very few. I think most of us who are experienced enough doing PCNL, you realize that if you choose your patient correctly, the risk of getting PCNL sepsis is not that high nowadays, with fantastic antibiotics and care for the patient. So yes, it's nice to do a gram stain if you have your facilities, but are you going to follow it? I'm not sure. I've read any latest literature on that. I'm sure they are, but I'm not well versed in that. Maybe Prof Islah can know a bit about literature on that. But my take is I won't do a gram stain, because my center's facilities don't have that kind of. I don't have that kind of facilities, and I've done PCNLs and not much risk of PCNL sepsis.
Okay, thanks for glad to your answers. So maybe I have a wrong question. I'm sorry that. So maybe preoperatively. So maybe can you put it into the stent or so nephrostome tube? So to get the urine stain to urine. So to avoid sepsis or urinary tract infections after PCNL. So maybe can you do that? So preoperative stent or so nephrostome. So preoperative PCNL procedures to get the ring.
Yeah, I suppose if you have a patient that you suspect has already have a pyonephrosis or infection, in fact, that's what I'm going to do. I'm going to put a stent on nephrostomy tube and not do a PCNL in the first place. I was involved in this initial study. I think one of the big papers was by Dr. Param, who's now in Edinburgh. He was my colleague in Penang, and the study was actually done in Penang, where we actually collected the urine specimen for an obstructed system when we did ureteroscope and look at the culture of the kidney and the culture of the bladder urine. They are different. So
Yeah,
a
right.
urine culture is not predictive. So, but if you have a clinical patient that you think already have a pyonephrosis or infection in the kidney, I totally agree with you, Prof Inoue. I would put a stand on nephrostomy tube first.
Okay, thanks again. Okay. So thanks for a great presentation. So both professors. So we don't have much time to discuss so about case report. I'm sorry that Professor Kid. Yeah.
No
So
problem. Another day.
yeah, right. So first session was done. So let's go to the next. So move on the next sessions. Okay, next session is ECIRS essays procedure from Japan side. I want to change the moderators from me to the Dr. Islah. So proceed talk. So Dr. Islah, it is on you.
Thank you, Dr. Inoue. Right. So we have finished the anti-grade approach. Now we are going for the retrograde approach. So for our first speaker, we'll talk about the tips and tricks in ECIRS. It's no need much introduction. Prof Shinsuke Okada, this the director of the Department of Endoluminal, Gotoku General Hospital, Chiba. He has a lot of publication. If you can see, there is more than 20 publications in a very recognized journals. All talk about this endourology. He has participated in many research, very well organized research, and a lot of grants. So please, Professor Shinsuke Okada, can you start your presentations?
Thank you for introducing me, Dr. Islah. Please start my.
Good afternoon, everyone. I'm Shinsuke Okada from Japan. Thank you very much for joining us. I'm honored to be here with you. Today, I'm hoping to give you tips and tricks in ECIRS. ECIRS is becoming popular in Japan, so today I will show you the details of ECIRS. ECIRS means endoscopy combined intrarenal surgery. That is, performing simultaneous retrograde ureteroscopy during PCNL. We are performing ECIRS with 3 doctors: percutaneous approach, retrograde flexible uteroscope, and a supportive doctor for its great saline irrigation of FURS. What does flexible uteroscopy bring in ECIRS? How is stone-free rate improve? How's the complication? It depends on the performance of FURS. Using flexible uteroscopy is required additional cost, of course more staff members and devices. In addition, understanding of the different surgical environment from PCNL is quite important. So to get good outcome, key point is how to operate flexible uteroscopy. So in today's presentation, first we will introduce the concept of ECIRS. Then I'd like to present outlines in ECIRS. Finally, I will show you specific techniques using retrograde flexible URS. Why we choose ECIRS over PCNL? It's related to the concept of ECIRS we think of. As you know, PCNL has an advantage in stone retrieval compared to ureteroscopy. Large diameter tract makes it possible to extract large stone fragments, which leads to shorter operative time. However, the working area through single tract using rigid nephroscope is limited, and multiple linear tracts are sometimes required. It has increased risk of bleeding. On the other hand, flexible uteroscope has a larger working range. It is possible to access most calyxes. The disadvantage is time consuming. We need to break stones into small pieces for basketing. ECIRS is a procedure that takes advantage of PCNL and makes up for the shortcomings of PCNL with uteroscopy. ECIRS can reduce the need for multiple linear tracts. In the latest systematic review, ECIRS has higher stone-free rates. Most cases were performed using single tract with conventional size around 24 to 30 French. Bleeding and transfusion rate is lower in ECIRS. Infection has been reported slightly higher in CRRS. ECIRS has the potential to improve stone-free rates and reduce the risk of bleeding. Next, I will introduce you surgical procedure of ECIRS in detail. In terms of settings, ECIRS needs standard equipment for PCNL and flexible uteroscopy, so two monitors and two restrictors should be prepared. Regarding personnel, two operator and one or more assistants are preferred. The position of the two monitors is quite important. Two operators need to track the progress of another operator to avoid a breakage of endoscopes or other complications. So, two monitors are closed like this and take care not to disturb the each views. This is surgical procedure. You can see the flow of ECIRS. Normally, after placing accesses, flexible URS is inserted. We create hydronephrosis for puncture using the saline irrigation from FURS. First step is patient positioning. This movie shows creating modified Valdivia position. Proper positioning is quite important to prevent the positioning injury such as nerve injury. Be sure to decompress the area of contact between the body and the operating table or devices. Next is placing accesses. The position of the tip of ureteral accesses is quite important in ECIRS. Saline irrigation pressure from nephroscope is stronger and it helps to the ureter, especially in prone position. It causes to migrate stone fragments into young ureter. So to prevent stone migration or retained URS, the tips is placed at the top of URS accesses near UPJ, especially in prone position. Next is renal puncture. Now, end-vision puncture has become well known. One of the advantages of using FURS is you can confirm the position of the puncture needle and check the bleeding status in real time. We believe it is important to achieve papillary puncture to reduce bleeding. End-vision puncture also allows you to check the condition of the tip of puncture needle, such as sticks into the mucosa of renal pelvis in this way, or non-papillary puncture with bleeding. Considering the appropriate puncture site, you can see hydronephrosis by ultrasound, where in kidney should be punctured in this case, which one is fine. To reduce bleeding, it is important to avoid the main blood vessels of the kidney during puncture. Ultrasound-guided puncture allows you to check the condition of surrounding organs in real time during puncture. Moreover, you can grasp the condition of blood vessels in the kidney. This procedure using wideband Doppler ultrasound guidance was reported by Professor Inoue, and it allows renal puncture while avoiding blood vessels. You can also use flexible URS when dilating a renal tract. Make sure the tip of the dilation device do not penetrate the renal pelvic wall, and you can confirm that there is no active bleeding during dilation. Endovision while dilating a renal tract contribute to the reduction of the radiation exposure. Next is regarding disintegrate stones. When breaking stone, you need to consider how to retrieve stone fragments. As with conventional PCNL, it is effective to break it into large pieces and remove it with a forceps when use the renal tract with large diameter. On the other hand, when using small diameter tracts, it is necessary to break the stone into small pieces, and the number is enormous, so in that case, the washout mechanism is quite useful. This is an ECIRS case using a miniature nephroscope. This is ECIRS case using a miniature nephroscope. Stone extraction with forceps is also possible, but by creating a retrograde active perfusion from the ureteroscope at the timing of pulling out nephroscope, stone fragments are washed out, enable efficient stone extraction. In order to use the washout mechanism effectively, it is necessary to pay attention to how to break the stone. In PCNL, the stone around the UPJ are usually disintegrated last to prevent stone fragments from falling into the ureter. On the other hand, in ECIRS, in order to effectively utilize the perfusion from URS, the stones around UPJ are first broken to create the communication space between nephroscope and ureteroscope. The washout mechanism is extremely practical, but you should be aware of sudden changes in the field of view of the ureteroscope. When the nephroscope is pulled out, the renal pelvis is rapidly decompressed, and the working space in renal pelvis disappears. This leads to urinary tract damage and the other endoscopic damage due to laser misshot. Cooperation between PCNL and URS is dispensable. Finally, I will show you specific technique of ECIRS. The first is through-and-through technique in percutaneous rhizotomy. If an antibladely inserted guide wire is placed in the ureter, subsequent procedures is safe. The reason is wire is hardly pulled out, and the mobility of kidney is restricted, so dilation of renal tract can be performed stably. Hold the insert guide wire with forceps and its guide to the ureter. Next is a pass ball. The working area of nephroscope in PCNL is limited, and not all renal calyxes can be observed. Flexible URS can relocate stones located in such calyxes to the working area of nephroscope in order to enable stone extraction with nephroscope, and multiple renal tract is not required using this technique. Finally, Flexible URS could play a leading role in ECIRS. Generally, if URS has a supportive role in ECIRS, this integrated part of stone passable, so the position of linear puncture is chosen considering more effective work of nephroscope. In this case, upper pole or lower pole puncture is better, but sometimes it is difficult to puncture the targeting calyx. If FURS has a leading role, we can choose any calyx which is easy to puncture with end vision. This integrating stone is mainly performed with flexible URS, and stone fragments are removed from linear tract with vacuum system. This technique is quite useful when using Cleopatra with vacuum system. This is the last slide, the summary of my presentation. The surgical environment is different from PCNL, so understanding is quite important. The performance of FURS determines surgical outcomes. Of course, contribute to better outcome and sometimes cause severe complications. And coordination between two staff is quite essential. That brings me to the end of my presentation. Thank you very much for your kind attention.
Thank you, Dr. Okada, for your nice presentations. We will leave the questions at the end of the sessions.
Yes.
So we will go for the next speakers, which is Professor Shuzo Hamamoto. He will talk about troubleshooting in ECIRS. Okay, Professor Hamamoto is from a senior lecturer from Nagoya City University, Graduate School of Medical Sciences. He has been director in Toyota Kosei Hospital before. Please, Dr. Shuzo Hamamoto.
Thank you, Dr. Islah. Please start. Dear colleagues, my name is Shuzo Hamamoto from Nagoya City University. I would like to thank the organizers of this event and Boston Scientific for providing me with this opportunity. My today's topic is troubleshooting in ECIRS. Endoscopic combined intrarenal surgery (ECIRS) a treatment that uses URS and PCNL. Specifically patient positioning, insertion of the ureteroscope, lithotripsy, and stone extraction. Therefore, in this presentation, I would like to focus on these 4 items. First, I will explain about troubleshooting in patient positioning. The position in ECIRS is changed to the positions of PCNL in addition to a leg spread position to allow for combined transversal manipulation. The most common positions are prone split leg and modified Valdivia position. The following complications regarding to positioning in ECIRS have been reported since 2016. Due to the modified Valdivia position, there was 1 case of compartment syndrome, 2 cases of sciatic pain and numbness, and 2 cases of DVT. We present a case of compartment syndrome. A 50-year-old man underwent ECIRS in the modified Valdivia position for a right kidney stone. His BMI was high at 26.3 and his surgery time was long. His intraoperative blood pressure was also low at 80 to 100 mmHg. 3 hours after surgery, the patient complained of pain and swelling in the left leg and increased pressure in the muscle compartment, leading to a reduction of the incision. The mechanism of this occurrence is due to impaired blood circulation in the lower limb associated with lithotomy position. In the lithotomy position, the blood perfusion of the lower limb may be decreased. Abnormal compression of the perineum causes increased pressure in the muscle compartment, resulting in edema and swelling of the tissues. Excessive tissue pressure within a closed fascial space creates the negative cycle, resulting in compartment syndrome. Patient risk factors for compartment syndrome include obesity, smoking, diabetes, hypovolemia, and surgical factors such as prolonged surgery, low blood pressure, and sequential compression device. Move on the case. Although the operation time was long and the intraoperative blood pressure was low, the contralateral perineum abdomen was easily compressed in the modified Bardier position. It is necessary to add a cushion to the pressure point and apply grade pressure. I will show you to create a modified Bardier position. Since the levitator is used in the oblique position, the area to be compressed is differently from normal. This picture shows the left ECIRS, the inner side of the left knee joint, the outer side of the right knee joint, and the right thigh are easily compressed and need to be cushioned. Next, I will show you the precaution to be taken when inserting the flexible laparoscope. There are 5 advantages of using flexible laparoscope in ECIRS. The first to create hydronephrosis by puncture, and the second is to be able to perform a renal puncture with the assist of a flexible laparoscope. Others include retrograde irrigation, bilateral lithotripsy, and passive ball. However, the problem is that it requires the insertion of lateral access cyst. The lateral access cyst serves to aid in the insertion of the laparoscope and prevents stone from migration into retube. Usually, it is common to insert to the UPJ position. However, a mismatched access cyst causes the risk of lateral injury. Similar to URS, if the access cyst is inserted forcefully, lateral damage to the surrounding fat may be observed. To avoid lateral injury, lateral findings should be obtained by rigid laparoscope or retrograde pyelography. A thin access cyst should be used, and in some cases, cystless procedure should be performed. It is best not to insert forcibly. Next is a discussion of troubleshooting in lithotripsy. Lithotripsy in ECIRS is efficient when performed simultaneously, from the PCNL side using a lithoclast and from the URS side using a holmium laser. This type of complete Stockholm calculi can also be eliminated in a single session with an efficient use of retrograde URS and antegrade PCNL simultaneously. However, if they do not work well together, it can lead to complications. One of them is damage to the scope This picture shows damage to the ureteroscope and the laser irradiation screw caused by the laser. To prevent equipment damage, it is important for surgeons to communicate with each other. This picture shows a kidney stone that has migrated into the uretube. If the stone is fragmented too much from URS side, it will migrate into the uretube and form a stone street. If this happens, it is necessary to push the stone back to the renal pelvis. If it is unable to push the stone backward, it causes only damage the ureteroscope, but also causes the stone to migrate outside the uretube, resulting in post-operative ureteral stricture. This cause, unfortunately, required a ureteral anastomosis. This video is a VR image of the ureter running in the modified Valdivia position. The ureter runs in this way. Around the UPJ position, the ureter runs from ventral to dorsal. On the other hand, in the prone position, the ureter runs almost horizontally, and the UPJ shows that the ureter is lower than the renal pelvis. In the modified Valdivia position, the ureters are higher than the kidney, so stones are less likely to migrate into uretube, while in the prone split leg position, it is the opposite, so stones are more likely to migrate into the uretube. To prevent stone migration in the uretube, it is necessary to extract stone fragments from the tract as possible. For this purpose, it is important to penetrate the PNL and URS slide to prevent stone fragments from falling into the uretube. Finally, I will explain the troubleshooting in stone extraction. In the case of ECIRS, the operation of extracting the stone from the tract using retrograde irrigation from the URS side is effective. This method is known as the washout mechanism. This was reported in 2014 and compared the results of conventional PCNL, mini PCNL, and mini ECIRS. The surgery time is longer and the stone-free rate is lower in mini PCNL than in conventional PNL. However, by using the washout mechanism, mini ECIRS could shorten the operation time and increase the stone-free rate compared with conventional PCNL. However, this washout mechanism may increase the risk of urinary tract infection. Showing the result, you can see the risk of fever and sepsis is higher than conventional PCNL. This is the treatment outcome of ECIRS as summarized in a recently reported multicenter study in the SMART study group. This study also showed a very high rate of fever and sepsis. Furthermore, a multivariate analysis of risk factors revealed that surgical time, positive preoperative ring culture, prone position were risk factor of UTI-associated complications. The higher risk in the prone split leg position may be discussed in terms of uroflow dynamics and intrarenal pelvic pressure due to tract orientation. Furthermore, we considered increased intrarenal pressure as one of the causes of urinary tract infection. This will be a study in which intrarenal pressure measurement was performed when performing ECIRS. For measurement, a flexible ureteroscope with a double channel was used to measure intralinear pressure. The variation in pressure was highest during linear puncture and decreased with tract insertion. Pressure in the linear pelvis is probably higher than conventional PCNL. This is followed by penetrate the PCNL and URS side, which further reduce the intralinear pressure. This suggests that to prevent post-operative infection, it is important to control retrograde irrigation and to shorten time until penetrating. The risk of sepsis increases when the linear pelvic pressure is greater than 30 mHg. In ECIRS, bilateral irrigation, mini tracts, and the prone position appear to increase the intralinear pressure and cause post-operative fever. To reduce post-operative infection, it is necessary to shorten the surgical time until penetrating the PCNL and URS side. And additionally, it is necessary to synchronize to the timing of stone extraction and to use a pressure control pump. Today, I have explained about troubleshooting in ECIRS. ECIRS has characteristic complications by using the simultaneous use of flexible laparoscope. In creating the position, it is important to understand the characteristic of the position to apply slow pressure as appropriate. In inserting the laparoscopy, to avoid forceful insertion of the lateral accesses. I also mentioned that PCNL and URS should work together to achieve efficient restripsy after tract creation and avoid forceful retrograde irrigation during stone extraction. I hope everyone understands these points and perform ECIRS safely. Thank you very much for your kind attention.
Thank you, Prof. Shuzo Hamamoto. We will leave the question at the end of the sessions. So we will go to the next speakers. No need introduction. Professor Takaaki Inoue, my friend, okay, is now the Vice President of Hara Genitourinary Hospitals and Head of Stones. Has published multiple publications in well-recognized journals, more than 30, has presented a lot about his endourology experience. Please, Professor Inoue.
Okay, so thank you for introduction from me. So Professor Islah. So let's get started my semi-live video.
Again, hi, I'm Takaaki Inoue from Japan. Thank you for your invitation to talk my second topics. Yes, my topic is how I do it, minimally invasive endoscopic combined intrarenal surgery for kidney stones, like stagnant stones. This time, so I share my experience, case discussions. Let's start my presentations. Please see it. This patient age is 50 years old and male. His chief complaint is macrohematuria. After visiting my hospital, so we diagnosed his left side kidney stones, big stones. So the stone diameter is 4.65 centimeters. CT value is 1,625 Housekew unit. This is a 3D CT imaging. So so satellite, some stone fragments present in the ureters and anterior, maybe lower pole calyx. And then so in linear pelvis correcting system, so over than 4 centimeters big kidney stones is here. This is a CT scan image. You can find a big stone in left side correcting systems. Before operations, we discuss about puncture site or procedure management. So you can choose any puncture site upper or middle or lower pole. So which is a better puncture side? Usually, in this case, upper pole puncture would be better, I think. So you might choose this side punctures from upper pole. However, upper pole punctures has a lot of complication rate, so higher rate compared with another puncture site like a middle or low pole. Therefore, if you have another choice like endoscopic combined interlinear surgery, ECIRS procedures, so you can choose the ECIRS procedures in these cases. So we select the middle pole punctures and assisted flex ureteroscope retrogradatory. And then we can avoid bleeding complications and multiple tract in this case. Therefore, in this case, we determine the ECIRS procedures. So we choose some specific patient positions, like modified bird flank flip positions. So like image. The modified bird flank flip positions consist of under supine with distotomy positions and upright positions about 40 degrees in the hip portion. I show you ECIRS live surgery. ECIRS had two surgeons, percutaneous side or lateral side. In this case, we use ultrasound with Doppler ultrasound. This is a wideband Dopplers. Under the ultrasound guidance, we do punctures in the middle pole like this. Of course, simultaneously, we use the flex ureteroscope retrogradely. If it is possible, we can see the puncture side like this. This is a rare time. Very safe punctures. If you flex ureteroscope retrogradely, we can confirm the correct punctures and degree of bleeding due to needle puncture, I think. If having some pulsatile arterial bleeding from puncture side, so you have to repeat needle punctures again. After performing needle punctures to correcting portion and confirming no bleeding from our puncture side with the retrograde flex ureteroscope, we continue to dilate percutaneous tract flexuously. Of course, we dilate under direct visions of flex URS retrogradatory. Therefore, so the degree of fluoroscopic time is degrading compared with normal ultrasound punctures or fluoroscopic guidance of punctures. Luckily, so we can do the puncture side real time under direct visions of flex URS. So we check every step of dilations in the percutaneous tract. These steps under direct visions result in less fluoroscopic time, less radiation exposures for patient and medical staff. Continuously, we proceed to dilate percutaneous tract gradually. And then, of course, we put on the safety guide wires two guide wires, working guide wire and the safety guide wire, like this. After pressing two guide wires, working guide wire and the safety guide wires, we fixed the safety guide wires in the scheme. I think safety guide is very important when doing a PCNL or ECIRS procedure. If we have some happening, like bleeding or disorientations, at that time, so safety guide wire is very helpful for us for my surgery. So I think in Japanese situations of broken stone surgery, I think almost we use the safety guide wire. Anyhow, in this case we use the mini perk Vicar starts. I mean the minimum invasive endoscopic combined inner surgery. We now use the 16 French Parklands tract because a metal tract. Since 5 years ago, I don't use the Amprats or balloon catheters over than 20 for French metals, Parklands tract. We prefer to use minimally invasive tract. So like 16 French matter or 18 French matters. Of course, sometimes 20 French matters. But so as current development and innovations of restrictor, I mean braking instruments like lasers or Resocluster masters, ultrasonic. So this device is very useful, helpful to break the stones with a narrow tract size. Okay, so we had created Parkinson tract, incorrect tract side. We check the degree of bleeding from the linear parenchyma. So bleeding degree is very less. After checking bleeding degree, we use the vacuum devices, as I said before. So this is a Cleopatra devices. Indeed, this device is a very useful instrument. This Cleopatra is doing a little sections continuously during foreoperation. So we are breaking the stones because there's so tiny stone fragments is originated when doing surgery. These tiny stone fragments is aspirated continuously through this Cleopatra tract. Of course, in a literally bit bigger stone size fragments, we can aspirate through the Cleopatra tract by pushing another side forward to add the suction powers. As you can see, the speed of our sections is very faster, I think. We can easily aspirate some tiny stone fragments, a little bit more bigger stone fragment, I think. So we repeat breaking the stone, infection of the stone fragments, breaking with stone, the sections of the stone fragments. many times. So therefore, we don't use any stone basket or so any house apps. Although I see this tiny a lot of fragments. However, by using suction devices of Cleopatra, we can easily discharge these tiny stone fragments through the tract. Before using these Cleopatra devices, so we spend a lot of time over ECIRS procedures because at that time we used the stone forceps or stone basket to remove the old stone fragments during surgery. It is not easy to easily remove old stone fragments by using a forceps or basket. But after using Cleopatra's, operation time would be shorter than before. In this case, mainly we performed a fissure on the side to break the stones. But of course, some fragments are presented in the another calyx, and then by breaking the stones, some tiny fragments is spreaded a lot over space, a lot over calyx. In meantime, flexible rhetoroscope during ECIRS made a great role to displace the stone fragments and access to every calyx. Even if patient or side cannot access the stone site, like upper pole or the lower pole, so flexible URS is very helpful to access. And then flexible URS replace stone fragments to tissue and tract practice. This is a possible technique. As you can do movies, in this case we get a stone free. So very clear correcting systems. Finally, in our case, we check the percutaneous tract whether bleeding is or not. In this case, we don't have any major bleeding, so we try to do the tubeless. This is our clinical outcome. We experienced a minor bleeding, and we judged this endoscopically, so stone free. But next day, after operations, you can see there some stone fragments in a KUB imaging study. This patient don't have any experience after operations, so on post-operative death rate, so he discharged from our hospital. This is at 1 month after operations. The KUB revealed and later some dust in the lower pole kidney stones. I think this is real. So I'm very happy to meet first time. So after end of COVID-19 pandemic, so I hope to see you again. Thank you.
Thank you, Prof Inoue. So we go for the question and answer. I think the first one goes to Professor Shuzo Hamamoto. Question from Professor Cho. So how can we reduce the fever and UTI case post-operatively if we make 2 tracks working and additional with the increased intrarenal pressure? What do you think, Professor Shuzo Hamamoto?
Thank you for your question. I agree with your comment, but 2 tracks may have a larger track diameter, and spend time to make the second track. I think to reduce the reduce the infection. If possible, modified Valdivia position will be selected, and it is necessary to shorten the surgical time until contacting PNL and nephroscope and URS. And I think manual pumping may increase the pressure in pressure. So we recommend the controlled pump pressure, pressure control pump. Okay.
Any opinion from Professor Okada or Professor Inoue?
Yeah. So very good questions. I think so maybe to prevent a postoperative fever in the UTI case or after ECIRS procedures. So according to the Hamamoto's manuscript report, so maybe after doing the ECIRS procedures, postoperative UTI a little bit raised. So compared with the PCNL, why so increasing? I think. So maybe I think intrarenal pressure is a little bit higher. So maybe I think prone leg positions. So one of the reason is so bilateral. I mean the retrograde, antegrade, both approach. Yes, this is so one of the reasons. So maybe to increase the postoperative UTI, I think. So one, I recommend to decrease so rate of postoperative UTI. So I use now so maybe a Cleopatra vacuum devices. Yeah, so vacuum devices is one of the great role. So to decrease intrarenal pressures because Cleopatra named by the Cleopatras, so continuously so sections, so maybe in saline, so from the linear pelvis, I think. Therefore, so we can keep so lower intrarenal pressures during procedures all the time. So one of the so meaningful method, I think.
Any opinion, Professor Okada?
Thank you. Yeah, I agree with both doctors, Dr. Hamamoto and Dr. Inoue. And yeah, now Dr. Inoue recommends vacuum system Cleopatra. I also think Cleopatra is a very, very useful device to decrease intrarenal pressure. But I think to prevent post-UTI, perhaps drainage is better, especially for Stagford calculi. Yeah, perhaps breast stenting is, I think, I usually perform the breast stenting because the reason is, of course, one is the drainage and one is we expect is passive dilation. Passive dilation needs to make it possible to place accesses in ECIRS. So drainage is one of the good way.
Okay, there is one question from Prof Kim Hyung Jun. Wouldn't bilateral irrigation increase intrarenal pressure? Is there any guide for you to control from up and from down to reduce the intrarenal pressures? Anybody can answer.
Yeah, right. So from me, is that okay?
Yeah.
So very good question, I think. So bilateral irrigations, I think, increase so intrarenal pressures during real ECIRS procedure, I think. So even if so maybe a prone position, supine position, I think. So actually, so maybe a few months ago, so maybe I studied using a bench model, maybe a procan, so pig kidney, so to measure the so intrarenal pressures during ECIRS. So actually, so this outcome is so repeated. So retrograde irrigations, antegrade irrigations, simultaneous irrigations, so increase intrarenal pressures. But one way, I mean so retrograde irrigation only so antegrade irrigations, so intrarenal pressure don't raise. Yeah, therefore, so I recommend Yeah, so maybe a bilateral approach. So with the bilateral irrigations, so I don't recommend. So therefore, so maybe a PCNL side is main. So even if the ECIRS procedure, I think. And then, so if it needs, so if flexible URS approach is needed, so maybe I use the flexible URS in my institutions. Yeah, bilateral approach, so increase IPP. I think a rare operation, I think.
Any opinion, Professor Okada, Professor Hamamoto?
Yeah, I have my opinion is, I'm same as Dr. Inoue. Yeah, both irrigation cause increase intrarenal pressure. But I think it depends on the how to break down the stone. Of course, mainly using a percutaneous approach or flexible URS. Perhaps flexible URS needs saline irrigation to keep the vision. So if during simultaneous break stones, perhaps I think the irrigation pressure from nephroscope should be decreased. But when using the vacuum system, perhaps to extract the stone fragment using vacuum system, we need a lot of water, saline. So I think we don't need to decrease pressure of saline.
I'll go to the next question to Prof Hamamoto. There is one question, which operations suitable for PNL or ECIRS for over 3 centimeter PUJ impact stones? Because we don't have much times, so I'll go for the next questions.
Yeah, I chose ECIRS. In my institution, all case we select the ECIRS.
Any opinion?
So no PCNL.
Yeah. Any opinion, Prof Okada, Prof Inoue?
Yeah, both. But I think it depends on the institution, the experience. So better. So depend on the cases. If this cases has so maybe a hydronephrosis. So maybe I try to do PCNL procedures.
Prof Okada?
I think both are okay, but it depends on the situation. But if patient has another kidney stone, perhaps of course UPJ plus another upper calyx or lower calyx, perhaps we will choose ECIRS.
Okay, we'll go to the next question. If you use the clear Petra sheath, do you still aim to fragment the stone for retrieval, or instead you try to dust as much as possible? Anybody want to answer?
Yeah,
maybe
so
Prof Inoue?
Yeah. So maybe I used a lot of clear Petra vacuum devices in my institutions. So depend on the lithotripter kind of lithotripters. So I use maybe a hyperhomilic lasers with a Moses. Yeah, so during the ECIRS procedures, the Moses system is very useful to become a dot, to getting small dust. Therefore, using the Petra devices, so I try to dust because maybe it is easy to remove. So they're faster. So stone dust during the ECIRS procedures, I think.
Prof Okada, Prof Hamamoto, any opinion?
Yeah, I have my opinion. My opinion is, as perhaps it depends on the size of tract. Perhaps when you use a large size, perhaps break into the large pieces and extract it. It is okay. But if you use small diameter like ultra mini PCNL, perhaps dusting is better.
Prof Hamamoto? Any opinion?
Yeah, I have never used the clear petrol, so because of cost. So how do you think the cost of the clear petrol?
Yeah, so in Japan, so of course now, so we cover, so Cleopatra is covered, so health insurance now.
Okay, I have one question. Okay, do you use ultrasonic probe for ECIRS, supine PCNL?
Yeah, of course it is possible, I think, but it depends on tract size. So you depend on the using so nephroscope. So miniature nephroscope. So when using a miniature nephroscope, it is not so easy to use so ultrasonic, I think.
Yeah, that is my opinion also. Do you have difficulty when you put the ultrasonic because of the suctions functions? Yeah. Your visibility is a little bit difficult, isn't it?
Yes,
How about you? So. Yeah, Professor. Professor Okada, Professor Hamamoto, do you use for supine PCNL this ultrasonics?
Yeah, actually, our institute don't have any ultrasonics system, so we have only laser. I'm sorry.
Okay, Professor Hamamoto, any opinions? We have another.
Yeah, I agree with the Dr. Inoue's opinion. So depends on the tract size. We usually use mini tract, so we can in case of mini tract, ultrasonic is not available.
Okay, all right. We have one more question. I think we don't have much time for the case discussion. I think we have one more question. I think this is the last question. How to pass the pelvic stone in during PCNL endovision puncture, or do the puncture separately in huge pelvis and calyceal stone in ECIRS? How to pass the pelvic stone in during PCNL endovision puncture, or do the puncture separately in huge pelvic and calyceal stones in ECIRS?
You mean the under-dialect division, endovision punctures?
I'm not very sure about it. Okay. How to pass the pelvic stone in during PCNL endovision punctures, or do the punctures separately in huge pelvic?
Yeah, huge parts separately. So maybe I don't understand this meaning. Right? So,
maybe Dr. Sin Pyo, can you rephrase the questions?
So maybe
it means how to pass the ureteroscope through the around the stone to get the endovision.
So maybe how about so from the panels? So can you answer these questions? Okay, great. Yes, yes, Dr. Okada, yes.
Yeah. How to pass the scope?
Right.
Yeah. Okay. So sometimes, we cannot pass the ureteroscope through the stone. So in that case, before puncture, before endovision puncture, I break down stone using the flexible URS and pass the stone, and we can check the calyx using FURS.
There is one more question. Are we going to the question, or we are going to go for the next agenda? Questions. How to overcome the ureteroscopes? That is the next questions.
Yeah, maybe I think this means overcome the ureteroscope there. So maybe through big stones in the pelvic. Stones, right? Yeah. So I think in some cases it's difficult to pass the stone. So by using flexible ureteroscope, I think. Yeah. So in some institutions, so after breaking the big stones, so retrogradatory. So after that, so maybe a flexible ureteroscope can pass along the side of big stones, and then so maybe flexible URS reach the target renal calyx. So, but it takes a lot of time during operation, I think. I mean, so sometimes it is difficult to pass the stones.
Okay, thank you very much for all the speakers. I think we are not going to go to the case discussions. I think the time is up, so we'll go for the next sessions. Is it okay?
Yeah, right. Thanks. So
Yeah.
thanks.
Okay.
Thank you.
Okay, thank you for great presentations, all speakers, and the great moderators, Professor Islah. Thanks again. So, unfortunately, so we don't have any active discussion times. So now it's spent for 2 hours from starting these sessions. Okay, so maybe today's first lectures and second lectures is very impressive for me, and also that so impressed for the whole audience, today's participants, I think. Now we have already finished all sessions today, but before closing remark, so I want to introduce Dr. Lee from Taiwan to announce next instrument in February. So please talk. So Dr. Lee.
Yes. Good afternoon, everyone. Next month is the second episode of ETS, and this ETS was held by Taiwan and Vietnam team. We all together welcome all of you can also attend and register to attend the second episode of ETS. We also have many interesting topics. It include we will talk about the environmental factors in urolithiasis, and the expertise Professor Cho also will sharing his experience about the assisted single man surgery ECIRS. And the next Vietnam section will discuss about the non-muscle invasive bladder cancer surgery and the ureter stricture about the stent use placement. And the final, we also invite the Professor Jeremy from Hong Kong. He will talk about the inoculation of bladder tumor. We also will share some fascinating cases of the stone and the troubleshooting strategy in RIs. So we are looking forward to your attending, and please register to attend the second episode of ETS. Thank you.
Thank you for a great announcement from Dr. Reed. So we are looking forward to joining the next session in February this year. So before closing remark, so Professor Sung-Yong Cho, do you have some comments about today's first event?
This is actually Takaaki Inoue is the host of this event, so I don't have any comment. But I think today many people. I hope that many people enjoy the discussion, and they could get many solutions about their problems. So thank you so much for your efforts. Thank you.
Thank you for your comments. So again, we had done all today's lectures curriculum at once. I really felt all lectures and discussions are quite impressed for all audience today. I'd like to thank you all for great contributions on today's first event of ETS. So at the beginning of today, so we will establish the AUSET. This is an organization. So this is an Endoluminal and Technology Society around the whole Asia. So as the Professor Cho said. So maybe please keep in touch with us. So of course we planned next event. So maybe February in this year from the Taiwan, Dr. Lee. So finally, I'd like to say all stay safe and keep healthy with you and with your family. Today's thanks again. See you soon. See you next month. Goodbye. Thank you all speakers. Thank you audience. So thank you for all panels. Bye.
Thank you very much.
Thank you.
Thank you. Bye-bye.
Thank you. Thank you all speakers. Thank you, Dr. Okada, Hamamoto.
Recording stopped.
Great job, everyone.
Yeah, thank you.
Yeah.
Goodbye.
It was amazing.
Okay, bye.
Bye.
Thank
Bye,
you. Stay,
everyone.
Thank you. Bye bye.
Bye.
stay safe.
See you next month.
Yeah, of course.
Next month. Please save the date.
Bye bye.
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 Be safe. Thank you, Dr. Kid. Thank you.岡田先生、浜本先生、ありがとうございました。
お疲れ様です。
どうも、エビさん、もう開けてください。もう終わりました。
まだ繋がってんじゃないですか、先生、他と。
あ、いやいや、
切れてるんです。
ズームは違うんで大丈夫です。
お疲れ様でした。
エビさん、ありがとうございました。中下さんも。
ありがとうございました。
100人